Well, it's great to be here with Will and Sachin, and I know we're going to have a great conversation. I'm Dan Mendelson, and I'm going to be moderating this session. And the subject of the panel is the future of Medicare Advantage. Not an immodest topic, or maybe an immodest topic, but a large topic, and one that I'm sure we'll enjoy talking about for the next hour. And we're really fortunate to have two truly outstanding clinical leaders who've also seen a lot of different operating contexts and seen a lot of different ways of approaching Medicare Advantage in their careers. So I thought maybe it'd be fun to start with some biographical information, and specifically, I'd love to know from both of you, and Will, maybe I'll start with you, what you've learned about Medicare beneficiaries in the different settings that you've worked in, kind of how you see their needs, and what is it that Medicare Advantage can offer, and how that has woven through the different places where you've spent time in your career.
Yeah, well, thanks for asking, and great to see you, Dan, and of course, Sachin, always great to see you, and good to be here with the BMA folks. So I've had a bit of a circuitous course to my career. I've worked in a variety of different settings. If I were to think about the place that I sort of have the richest experience that really informs how I think about caring for our role day in and day out, for me, it's certainly the time that I spent as a clinician. Mm-hmm. I actually was fortunate enough to work as a clinician at the sort of side by side with Sachin at in Boston at Brigham and Women's Hospital. And when I think back,
I didn't know there was a related party transaction going on here.
Oh, there's a deep related party transaction.
Yeah, no, this is just the beginning.
This is a love affair that goes on for years. So.
No, but as I reflect on where I think the greatest learnings came from, it was taking care of really vulnerable, fragile people, and understanding that our patients day in, day out are dealing with complexities and real world challenges that are hard to it was hard for me to understand until I got really close to and really started to interact with on a very personal level with our patients. There was one patient that Sachin and I took care of together, who was an elderly patient. She actually worked at the hospital in which we were caring for patients, and she had all the access in the world physically to good care. She literally worked in the hospital, one of the better hospitals there are. But the system failed her. She fell through different cracks. She had problems with coordinating her care. She had problems paying for her care. She had problems even sort of with some of the administrative challenges to getting the right care. Mm-hmm. And it had really profound impacts on her long-term health. And I think those experiences, watching patients that you care about and that you know and that you've worked with struggle with the system, really highlights the opportunity that we have, the position that we sit in, humbly, this opportunity that we have to make it easier and make it better, make it simpler, make it more holistic, try to really understand the very, very personal challenges that all of our members face, and create the right infrastructure, the right resources, the right orientation, really the right focus to take care of people and not a constellation of illnesses or diseases. And I think that's what's beautiful about sort of the MA program, is its structure. The structure of MA positions us to think much more holistically about the population we serve, and to create and foster that kind of personal, service-oriented kind of relationship that really helps them on their path to better health.
That's a really thoughtful answer. It's interesting because you did not emphasize a number of other parts of your career in research, analytics. There's kind of more there, and I'd be interested in maybe hearing you fill in the blanks a little bit.
Sure.
Yeah.
So just a quick for those of you who I haven't met. I was a clinician and a researcher for a while, and actually I'd say my research was in another area where I think was a really good foundation to think about some of these, again, these personal challenges that our members face. My research was really focused on understanding how patients take their medications and trying to help patients improve their adherence to chronic medication therapy.
Mm-hmm.
And that's another behavior. We as in health plan, it's sort of the MA business, part of our goal is to really foster healthier behaviors. And that research, trying to understand what the barriers are and how to promote better adherence to chronic medications, really highlights this very, very personal process that our patients have with their health. And trying to understand the many different facets of behavior change and the many different reasons that patients don't adhere to the therapy. So my next job after that, I worked at the Innovation Center at CMS. In fact, worked with one Sachin Jain briefly in that setting, and then worked in the private sector since. I worked at CVS Health, at UPMC, in the health plan, and at the University of Pittsburgh Medical Center before joining Humana about a year and a half ago.
Well, Sachin, I think Will might have stolen a lot of your thunder here, but
yeah, I'm just going to sit back and let Will answer all the questions for both of us. No, thanks. So, I would agree with Will that, I think there's no substitute for clinical experience in terms of actually understanding what patients need and what Medicare beneficiaries really want from the healthcare system. That said, I'll hearken to A.G. Lafley, who was the legendary CEO of Procter & Gamble for a number of years. And what he taught the business world was, assume nothing about your customers. And it was a philosophy that I brought to my leadership of CareMore, which is where I was before I joined SCAN. And I implemented a practice there where I would have a monthly luncheon with a random group of members, actually, and just listen to them and talk to them. And what was illuminating about that experience was the extent to which it shattered my stereotypes about what Medicare beneficiaries want and need. I'll give you a few examples. We implemented a pilot. We were the first Medicare Advantage entity to partner with a ride-sharing company to provide member transportation. And I remember sitting with a group of these members and asking them how many of them had heard of Lyft or Uber. And zero members had heard of Lyft or Uber, right? And so here we were, very proud of introducing this innovation to the service of members. And the truth is that we were introducing something that they didn't necessarily understand. And so what we had to do was actually change our implementation and be the ride requester on behalf of the members. And that was an insight that really came out of engaging with consumers, engaging with patients in that way. I assume that our members were very, very interested in their medical benefits. It turns out a lot of our members here in Southern California care a lot about their teeth. And they were really upset about our dental benefits. And they actually, many of them talked about visiting their dentist more than they visited their doctors. And from that came this idea that we implemented, which was an integrated medical and dental clinic, wherein we used the dental office visits as a means of providing chronic disease management services to seniors. And then finally, around the digitization of care, we assumed that seniors didn't want to actually digitize care because that's what we had largely seen in the preceding decades, not necessarily recognizing how quickly the adoption of digital technologies was moving in the senior population. And I had this exercise of asking our members to actually pull out their cell phones. And during the early part of my tenure at CareMore, people would reach into their bags, the bottom of their bags, and they'd pull out a flip phone that was turned off. And by the end of my tenure, people would pull out smartphones that actually had apps and then would turn to their neighbor at these luncheons and say, hey, I use this app to actually track my medicines, and I use this app to track my care at this provider partner that we were working with. And so I think one of the challenges we have as non-seniors working in the senior care industry, is that we have our own stereotypes about what seniors want and what seniors need, most of which are actually not really true. And the other thing we do is we talk about aging adults like they're a monolith, and we assume that everyone is kind of the same. And in fact, seniors couldn't be as different as any other group of people. So there's a heterogeneity in terms of needs and wants and benefits. And so, I go back to what A.G. Lafley said, it's just assume nothing. And it's the thing I kind of preach in my leadership, first of Care More, now of SCAN. There's no worse mistake that we can make. And again, I would say in the health plan world, one of my greatest frustrations is how many people lead by anecdote. Mm-hmm. And they say, oh, well, when I went to the doctor's office, not recognizing and then use that to kind of drive decision making.
Yeah.
Because if you're sitting in an executive conference table at Humana or at SCAN, you're already kind of unlike most of the people you serve, and most of your experiences have absolutely no relevance to how we should be thinking about the design of programs or systems. But in fact, those anecdotes end up driving so much of the conversation and the benefit design, the policy changes. And so, again, I think we have to be super humble as we think about the design of care and benefits and systems and networks in the communities that we serve.
Yeah, super humble. And that's an incredibly insightful thought. And it probably also begs analytics or some way to kind of in a more systematic basis, really understand the populations that you're serving as well. You've actually started into, in some respects, the first place where I'd like to begin, which is to look a little bit at the growth of Medicare Advantage and to understand a bit about why it's happening. I'm a bit older than you guys. I'm not quite Medicare eligible yet, but when I was running OMB Health in the late 1990s, we had about 6% of Medicare beneficiaries opting into Medicare Advantage. And now you fast forward to today in 2020, we've got about 38%. It's growing by about 8% a year on a compounded basis. It is likely to pass 50% by 2024. So both of you are in the right place at this point if you want to really be affecting the trajectory of Medicare. Well, I'd like to maybe ask why you think there has been this much growth in the program, why you think seniors are opting into the program, and what are they getting out of it that is causing them to choose this way of getting their Medicare delivered to them. And Will, maybe I'll start with you again, since Sachin,
Sure.
I think, actually just leaned into some of these.
He did.
So you can start where he left off, and then we'll give him the last word.
Sure. No, that sounds good. The fact that that Sachin has had the opportunity to kind of sit with a group of seniors each week and to sort of think holistically about what those seniors need, what their challenges are, who they are, what makes them, what they're looking for in health, symbolizes what is, a special opportunity in MA. We structurally are organized to be able to we're forced essentially to think about how to optimize the health of the entire population we serve. We are, we're paid a fixed amount, and it is up to us to figure out how to leverage those dollars to produce the greatest amount of health. It's also up to us to figure out what our members' biggest challenges to finding their path to best health are, and to try to solve them. And that sort of orientation, that lens, I think forces us to think much differently about how care is delivered, how it's paid for, and how the actual service of care is delivered. We know affordability is a huge issue in healthcare today, and MA plans can be really thoughtful about how to create the right benefit structure, how to create the right network, how to create the right approach to make the most important care most affordable, to reduce premiums are considerably less in MA than they are in traditional Medicare, and out-of-pocket costs are considerably less. The BMA statistic I've heard is on the order $1,600 a year.
Mhm.
Healthcare is really fragmented in the US. Providers who often are responsible, each provider is responsible for a slice of care, don't have the same orientation as a health plan, or really think about how to coordinate the longitudinal features of care, and also to weave in behavioral health, to weave in social needs, to weave in pharmacy in a constructive way, to create a much more integrated set of solutions. We are in a much better place, or we're uniquely in a place to say, how do we take in an environment where I think we'd all agree that we are over-indexed on healthcare spending and under-indexed on social service spending.
Mhm.
We are uniquely positioned to be able to redistribute healthcare dollars to go upstream and to address health-related social needs and try to prevent bad things from happening, and to try to really sort of keep people healthy in the first place. We're similarly oriented around improving quality. It's a key part of how we're reimbursed and rewarded. And it is a critical orientation for us to try to not just think about the quality of care for a patient that's in front of us, but to think about how to go upstream and provide the right preventive care, the right chronic disease management. And when you put all those pieces together, I think you have a much more consumer-centric, affordable, simple process that, seniors are choosing with their feet. And I think it's because we're able to this marketplace is allowing us to innovate and really give them what they want.
Yeah. Again, it's a very comprehensive answer. And Sachin, I guess, one question I would ask for you to maybe even go a step further is, in terms of the clinical differentiation, you mentioned benefit design and Lyft and Uber and, transportation. There are a lot of benefits that are just not available to fee-for-service beneficiaries at this point, since they're not available in traditional Medicare. And I'd be interested from your perspective in whether some of the clinical differentiation, whether it be around medication adherence or whether it be around care coordination or some of the other things, are effective selling points for seniors, or whether they're opting in for the cost reasons that Will is outlining.
So I think one of the kind of key data points to look at to understand, the value proposition that I think people see in Medicare Advantage is the extent to which they're actually switching PCPs upon their switch into Medicare Advantage. And a number of folks will look at the set of benefits, and they'll look at the higher intensity of clinical services that are sometimes offered by Medicare Advantage plans, and they'll say, this is a better place, for me to get care. And so I actually think that there is a growing number of folks who are starting to recognize that there is a higher need for integration, there's a higher need for care coordination, and these extra layers of clinical services that are actually provided to members actually generate massive word of mouth in the community. Because, when you're a fee-for-service Medicare beneficiary and you're discharged from home and no one calls you, right? No one's checking up on you. No one's making sure that you have meals in your refrigerator when you get home. And then you talk to your neighbor who was also recently admitted to the hospital for, a similar condition. And they say, well, I had a home visit from, someone from my health plan. I also had, someone check up and see if I had meals in my refrigerator. And by the way, I have a ride to my, office appointment that was organized by the care coordinator. That makes a difference. And seniors talk. A lot of seniors have a lot of time, and they engage with each other in the community, and they talk. And the word of mouth actually is the most powerful driver, I think, of adoption of Medicare Advantage. When you really get down to it, when people age into Medicare, they ask each other, so are you in a supplemental policy? Are you on a Medicare Advantage plan? Or are you staying with you're riding, dangerously with fee-for-service Medicare? And more and more people are recognizing that they want to be enveloped. I don't think, though, that you can kind of bold and underline enough the cost point. One of my favorite acronyms in an industry full of acronyms is MOOP. And when you talk about a maximum out of pocket, fee-for-service Medicare has a MOOP of infinity. And Medicare Advantage has a MOOP of whatever it is. I think in Southern California, we're running at $800 or, something like that.
Yeah.
That's remarkable. And that in a time when more and more people are facing income insecurity, when more and more people are kind of trying to make their dollars stretch farther, an increasing swath of the American population, not just lower income Americans, as I think the stereotypes have applied to Medicare Advantage, but people who are truly middle class, and even folks who are upper middle class or part of other segments of society, are taking a look at this and saying, this is really, really good value. Mm-hmm. They've got access to the same specialists. They've got access to the same hospitals. I think one of the challenges we have in our industry is utilization management. It's one of the blunt instruments we use in Medicare Advantage that I think actually turns a lot of people off to it. And so, again, I think we have to, when I worked earlier in my career with Don Berwick, and we were writing papers on, prepaid medical groups and the quality of care in prepaid medical groups like Kaiser, he made an important point, which is he said, we have to show people the benefits of integrated and coordinated care, and not necessarily and lead them away from thinking about some of the downsides of integrated and coordinated care. And so, again, I think that is the challenge to the industry, is to show why being part of a system that offers you a narrower network but richer benefits ultimately leads to better outcomes. I think that's the challenge that we have in front of us.
Again, very thoughtful answer. I want to, before we move on and talk a bit more about the pandemic and the recession, which I think is kind of embedded in some of what you're talking about, I want to ask one more question on this topic. It has sometimes been said, and some of this comes from beneficiary advocacy, that Medicare Advantage is a great place to be when you're healthy, but not when you're sick. And that if you have, serious chronic illness, late stage cancer, very unusual disease, that you might have more difficulty in Medicare Advantage versus in fee for service. And in some of the answers that you've given so far, you're kind of referencing seniors who are kind of on their feet. And I'm interested in hearing from both of you briefly as to kind of how you think about the more intensively ill patients and how these concepts apply to them.
I'm happy to take the first crack. I think I think I would position it differently. The folks who are really, really complicated and who are in it have advanced illness, they need care coordination more than anyone. Not just coordinating clinicians, certainly clinician care, being able to sort of coordinate a specialist, a primary care doc, maybe a palliative care doc, but also coordinate, again, the sort of social needs, which are often really, really challenging. And frankly, supporting caregivers, supporting the family. The burden for caregivers in advanced illness is quite remarkable. And Medicare Advantage plans have the ability to sort of look at that broader picture, to both coordinate the clinical care, to try to integrate more of the social context, and to think more broadly about that patient's family and how they're being impacted. I think one of the challenges previously had been that there was this sort of awkward benefit challenge around hospice. And members at our MA members had to make this decision. They were getting care from a system, and then they had to make this decision. Am I going to continue to get curative care, or am I going to switch to getting palliative care and to enter a hospice program? And that sort of dichotomous decision was and is a tremendous barrier to easing into a different paradigm of care. And I think it caused patients and families an incredible amount of stress around making that decision. The new CMMI model that allows MA plans to carve in hospice, I think, will fundamentally change that, and it'll allow a more progressive, a more patient-centric, a more family-centric, a more just a more compassionate way of having these conversations about advanced illness. And I think that'll be a really important facilitator as we as that model, which initially is a test, as that gets expanded and spun out.
That's helpful. And I think, in some ways, growth in Medicare Advantage will really depend on bringing in these populations. And so that's, kind of in the context of why I'm asking. We'll certainly be coming back to this. Sachin, both CareMore and SCAN certainly work with a very diverse population. What's your take on the question?
Yeah, I mean, the question, for me is a hard one to answer because I've kind of worked in two organizations with a long history and real heritage of focusing on, caring differentially for the sickest of the sick. I think we need to rewrite the script on how we think about healthcare more broadly, and I think MA is probably the best place to do it. One of my favorite little factoids about this industry is, the average tenure that someone remains a Medicare Advantage member. Most of us, I'm curious about Humana's number, but at SCAN, CareMore, on average, we keep someone for 9 years. That gives us a 9-year, investment horizon to think about the things that we can do as a healthcare organization to keep patients healthier longer. And at the end of the day, the right question isn't like, how do you handle people who are on the tail end with multiple complex illnesses? The right question is, how do you prevent people from actually getting there, right? How do you take somebody who's got stage 1 or 2, or even 3 or 4 CKD and make it so that they never get on dialysis, as opposed to ask the question like, can they access Fresenius or DaVita? So I think we have to kind of reframe the conversation. We are going to enter an era of just tremendous innovation in cancer diagnostics. There's going to be a Medicare Advantage plan that's going to offer people, regular screening, regular blood tests for cancers that today are undetectable prior to stage 3 or stage 4, before they've metastasized. So I think the challenge to the industry is to be clinically sophisticated, preventative, thoughtful about upstream management, and stop fighting this fight about what are we going to be doing on the tail end when people get really, really sick, and start fighting on the end of how do we make sure people don't actually get sick. And that when they are at a point where they're ready to pass on, they're choosing palliative care and hospice as more humane approaches to the end of life than what I think the fee-for-service system traditionally dictates and drives, which is, kind of the revolving door of specialist, primary care specialist, hospital, primary care, SNF, hospital, right? So that's the world of the average Medicare beneficiary in fee-for-service with total lack of coordination. We can't be defending this ugly status quo and kind of creating a this or that. We've got to, I think, project a vision for an even better future and, collectively drive our industry there. Now, I think the challenge to all of us is to make sure, we are building the kind of care coordination and systems that, I've had the privilege of kind of leading in these two organizations, and that I know Will is driving at Humana. The most cynical view of our industry and its approach to taking care of the sickest of the sick is that it's just a big risk adjustment machine, and we're driving up the bill for the federal government. And at the end of the day, if we're going to code more and we're going to receive more revenue, we actually have to do more, and that is, and we have to provide more for the American public. So my personal perspective is that there's a lot of work to do on that domain, because I think a lot of organizations are defining success, and you're seeing this in kind of the IPO market in the space. A lot of folks are defining success here as low medical loss ratios, and they're tricking people, because low medical loss ratios aren't just a function of superb medical management; they're also a function of superb revenue management.
Right.
And that's a huge problem that no one really wants to talk about. Medical loss is medical expense over medical revenues, and you can get a really great medical loss ratio by being very good at risk adjustment and coding. And again,
Mhm.
these are uncomfortable conversations,
Yeah.
but they're important conversations, particularly in forums like this one.
Very important. And, that also, by the way, raises the question of how sensitive our quality measures are and how we're really, kind of monitoring and raising the bar on what constitutes quality in the system as well. So to me, those questions are very interrelated.
Yeah, Dan, on that point, I just wanted to say one more thing, which is, I think, you asked this question about why Medicare Advantage versus, traditional Medicare. Another thing I would just say is the STAR system is a really clean proxy for people on whether they're actually getting, a good system or not. And, if they can reliably be in a 4, 4.5, or 5-star plan, of which, there are many at Humana and many here at SCAN, that actually creates some greater confidence that you're in a high quality, high benefit, system. What do you have when you're fee for service? What are the ratings you look to see that you've got a good, system there? So I think that's another point that makes it very attractive.
Point being that there isn't one. And Sachin, I'll point to research that my firm, Avalere Health, did for BMA, where we did a matched cohort analysis and looked at the standard quality measures ranging from, cholesterol to screenings to other of the more clinically oriented measures. And we found that consistently and predictably, by the way, beneficiaries who were in Medicare Advantage consistently had much better outcomes than their fee-for-service cohort. And it's both predictable, but I think there are a lot of members of Congress don't really understand that, and I think that a lot of seniors, frankly, don't really understand that. So in terms of thinking about the script, that's the kind of work that BMA has sponsored, and the kind of work that I think is really quite important for defining a bright future for Medicare Advantage.
Yeah, Dan, I think one of the challenges we have, from a members of Congress perspective, is that this industry has an image problem that goes back to, some of its earliest days. Sure. When, there were a lot of for good
reason, by the way.
Yeah, there were a lot when you were at OMB, and when there were a lot of wildcat health plans that were, kind of introducing weird benefits and signing people up, and it isn't that anymore, right? And so I think, again, part of the challenge for this community is to make sure we are doing a good job, to your point, kind of telling a quality story, telling a cost story. Amol Navathe, a close colleague, friend at Penn, and I recently published a paper in Health Affairs along with Brian Powers, who works on Will's team. It's all very incestuous. Looking at the quality of care in an ESRD CSNP that I used to operate, and we were able to show a mortality benefit that I think shows, again, even when you're taking care of some of the sickest patients with ESRD, you end up delivering better outcomes. And so, again, we need more proof points like that to be able to change the story away from this wild west of Medicare Advantage that we used to inhabit.
But there's a little schizophrenia here, and I think there is sort of a very vocal minority, frankly. There's each year there's a letter that's passed around in Congress, and last year over 400 senators and members of the House signed a letter in strong support of the important role that Medicare Advantage plays in promoting the health of seniors. And it was a relatively even split of Republicans and Democrats. You have one or two presidential candidates that speak very overtly and in sort of rather disparaging terms about an industry. And I don't think that reflects where our governing body is today and what most people think about Medicare Advantage. And it's hard, I think, because people think about an insurance company in one way. On the other hand, when you look at what most MA plans are doing today, we're not insurance companies in the sort of very traditional sense of the word. Increasingly, we're all figuring out the role we can play in delivering care in addition to paying for care. So you've got, United is now the biggest employer of primary care docs. CVS has a clinic in pretty much everybody's neighborhood in the retail setting. We have we've made a big investment in care in the home. if you look across the industry, in MA in particular, MA plans are innovating to try to figure out where they can fill in the gaps and where they actually deliver care.
Mhm.
And that sort of some of that, those bright lines between what is a trusted doctor and what is a scary health plan really
Mhm.
just don't apply at all in today's
Yep.
ecosystem.
I want to shift gears a little bit and maybe talk a bit about the pandemic that we're all in that's forcing us to put our faces in small boxes as opposed to like actually see each other face to face. And
Haven't heard of it. I don't know
yeah,
what you're talking about.
exactly. And this is obviously an existential crisis that's facing Medicare beneficiaries. It's also facing the healthcare system, and maybe get a sense from both of you as to how, as organizations, as Medicare Advantage organizations, you're responding to the pandemic, helping your patients through it, engaging in the delivery system to make sure that things remain stable. What is your response, and how does that support some of the answers that you've given so far in the discussion that we've had?
I'm happy to take a first crack at this, Sachin, and then you kick in. I think it's a really good proof. I think the pandemic really highlights, at a time where there are many, many fault lines in our public health system, in our healthcare delivery system. It really highlights how MA can fill a lot of those fault lines and really support members through this very fragmented and uncertain process that they're experiencing. On the one hand, I think the MA plans in general have been very proactive about coverage and making sure that there are no financial barriers to COVID testing, COVID treatment. The plans have largely been very proactive around eliminating cost sharing for telehealth, eliminating cost sharing for primary care, to try to make sure that patients have access, and there's no real limitation. We get as many barriers out of the way in terms of patients getting their usual source of care. MA plans have been very proactive around getting more care to the home. We're doing COVID testing in the home. We're sending preventive screening tests to the home, trying to make sure that at a time where patients or members are afraid of getting to going to the physical offices of providers, we're simplifying that. But I think the biggest thing is that we're all making proactive calls to our members in a systematic way. And at a time where, every one of us, Dan Mendelson, I'm sure you've had some really hard things that you've dealt with over the last 6 months, if not for yourself, for your kids, or for your parents. We're all struggling in one way or another. And this was totally uncertain, totally unexpected, where everyone has new challenges. And our ability to make proactive calls and ask people, hey, what is it? What are your biggest challenge? What are the things that are interfering with your ability to be healthy? And whether it's social needs, whether it's sending them masks so that they'll feel comfortable when it's time for them to go back to the doctor, whether it's, we've sent out over 1 million meals to patients because it's hard for them to get to the store. It's allowed us to really take a very, it's the same theme, a really holistic view of what our patients need. The other thing is we can also support providers in unique ways. As we all know, in MA, there's a lot more value-based care than there is in any other domain in healthcare. Mm-hmm. It gives us an opportunity to be more, make advanced payments, to partner in different ways because we are financially aligned, and we've all, reduced utilization management in different ways to facilitate more rapid access to care, in particular in settings where there are issues of capacity. As a system, we in MA are just in a way better position to look at the landscape and say, well, where can we play a role and actually be part of the solution? Mm-hmm.
That's great. Sachin, you want to add anything to that, or?
Yeah. I mean, we're doing everything Will's doing, and no, I'm just kidding. No, I mean, we're very similarly. I mean, there's a high degree of outreach and focus. We actually have a senior advocate program, which is actually a group of SCAN members who watch out for other SCAN members, and we activated that group of people to really check up on folks, make sure we understood their needs. If there were benefits that could potentially benefit them, help them navigate access to those benefits, including meal programs. One of the unique things that we've introduced is actually tech support actually for our senior population, as many of our partner provider groups are actually transitioning to virtual care. One of the capabilities that we're launching, or we've launched, is really around actually making sure that seniors know how to use the equipment and technology that is now in their homes.
It's
And
very important. I was curious that Will didn't dwell on telehealth, because I know they're doing a lot.
Yeah, no, I mean, it's true, but we could be here all day. I mean, the truth is that if you ask anybody at an MA plan, I don't think we're special. I think this is such a unique time, and we all had the orientation to say, all right, how can we be part of the solution? I do not mean I say what we did in a very humble way, because I'm sure we didn't do everything right, and I'm sure there's more we could have done. But our orientation, and I believe wholeheartedly from talking with colleagues at the other MA plans, the orientation of if not all, the overwhelming majority of our colleagues was to say, holy smokes, this is going to be really hard for our members, and we got to figure out what we can do to be part of the solution. Yeah. And what Sachin just brought up is it highlights what's great about MA is that we didn't all do exactly the same thing. There's not a playbook. There's not like, this is a case where there's definitely no playbook, right? There was nobody saw this coming, and nobody had a evidence-based approach to address the COVID-19 pandemic. But Sachin and his team came up with some really cool, creative stuff to implement. And I think you go ask any MA plan, we're all innovating, we're all being creative, we're all trying to figure out how to get.
And I think the bigger argument here, Dan, is we've figured out, and I hope that this is a lesson that actually sticks, is that it shouldn't take 10 years to like make simple modifications to our platform in the delivery of care. One of my great frustrations, and Will's known me since I was a medical student, is how long it actually takes to get anything done, common sense things done within a system of care and a system of financing where everything is tuned around a leadership style of consensus and thoughtful decision-making processes that actually don't enrich the quality of the decisions we make, but make us feel better about them. Yeah. And what's been fascinating about watching the morale of leadership in these times of crisis is that morale is actually really high because there's a sense of common purpose, and we're making more progress towards reinventing and reimagining our healthcare system in a matter of weeks than we probably did in the preceding decade, to borrow from that famous Lenin quote. And so the thing I'll just say is, I think that's the one thing I would say we need to really think about as an industry is how do we get out of our own way? Yeah. And how do we actually be leaders in the true sense of the word, and not, I would say corporate consensus builders, which is what we sometimes call leadership in these wide, complex matrix organizations. I remember, catching up with Will in the earliest days of this pandemic, and he's like, I've never worked harder than I have, in the last couple of days, but I've actually never felt like I've made more of a difference. Mm-hmm. What if we all felt that way every day, right? And not just in this kind of surreal time of a global pandemic. Really. And so,
yeah. And so the question I want to ask you though, Sachin, and kind of along those lines is, if you were going back into the government, next year or whenever, and you said, well, there are certain things that we should be learning from this experience that the government should be learning in terms of the administration of Medicare Advantage. What would you like CMS to be doing differently? And what do you learn from this? And it could be as specific as something around telehealth or something as general as, allowing innovation. But I'm curious kind of what you think this means for the future of Medicare Advantage, what you've seen so far over the last year. I'd like to hear from both of you on that. And let me also say before you answer, so we have about 10 minutes left shockingly, we only have about 10 minutes left, and I want to invite our listeners to ask questions, which we can integrate into the final 10 minutes. And I'm going to respectfully ask both Sachin and Will to make their answers a little bit more concise right now, so we can cover a little bit more territory.
You got it. We'll shut up. So I would just say, the key challenges that we have, and I think they're shared across the industry, is, we're paid based on, our code capture, appropriate code capture, and we're also paid based on the extent to which we have, we actually can close star measures. And the truth is that in these surreal times, that these two components have become very, very challenging. So if I were, kind of magically made, CMS administrator in a Biden administration, I would say we got to look at all these kinds of things and try to make it as easy as possible, but also be fair and reasonable so that it doesn't become a boondoggle for the industry either, because I think that will set us back. I'm really worried, honestly, about, some of the kind of profits that managed care companies are posting this year. They have to post them, but at the end of the day, people will look at that and say that's, as instead of it being a structural issue, which is what it is, they'll look at it and say this is, corporate greed or whatever, whatever it is. So the image on this on MA could change very quickly. So I would focus on the structural components to try to make it kind of more equitable and durable through a number of different circumstances.
Mm-hmm. So. Great. Will, how about you on that one? Well,
I really hope that there's a way to communicate more broadly that there is an MLR that is a backstop here, and that we're not all making, that is a from a profit standpoint, it's, where the taxpayer is protected. I think that for me, as we're looking at a time where uninsurance rates are going to go up and issues around the economic downturn is going to really impact a lot of people's pocketbooks. Mm-hmm. Coverage, affordability are only going to be increasingly important issues. And as we think about ways to solve that, I hope that MA can be an important chassis to address both. That expansions of MA into either a lower eligibility or, yes. So if we were to make Medicare eligibility a lower age, that would offer more opportunity for more members, more Americans to benefit from the structure that is MA that can produce better outcomes, more customer centricity, and more affordable healthcare.
Mm-hmm. When you think, so thinking more about the future, the long-term future of Medicare Advantage, we're at, let's say, call it close to 40% now of Medicare beneficiaries are opting in nationally. Of course, in some markets like California, it's already well over 50%, but we're kind of getting up to the point where it's becoming the majority as opposed to the minority. And I'm interested in if you think about the growth of Medicare Advantage in the future, where does the growth likely come from? And does the government need to change its policies, whether it be in rural underserved areas or in dealing with patients with certain types of illnesses? Does the government need to change policies to allow plans to better accommodate geographies as well as groups of patients? What kinds of changes do you think might be necessary in order to make sure that these programs are available to a wider swath of Medicare beneficiaries?
Well, what I'll say is I think you've got to look at, anytime there's an undersupply of something, it's just you're being underpaid for it. So if I were thinking about policy solutions to incent MA in rural areas, I'd be thinking about some sort of HCC modifiers, some sort of a modifier for underserved areas that gets you more capacity. I know that we have that in some geographies, but maybe they're not in the right geographies. So I'd be looking at kind of more broadly introducing modifiers in places where there's lower income. I do think that the uniquely American solution around Medicare for all is really going to be Medicare Advantage for all. Will and I have spent some time talking about this. I think it's a little bit self-serving for us to talk about it here, but at the end of the day, it's this uniquely public-private, solution that I think, could be very compelling in an American context. And so I think we have to introduce these types of modifiers to become available, to make MA available everywhere, because I think that is the future.
I'm going to ask one more broad question before we go into, some lightning round questions, and just to get your thoughts. Summer, we've seen kind of an unprecedented focus on racial disparities in healthcare. Very, very important topic. There's actually going to be a whole session on this later in the conference, so I don't feel like we have to completely, take all of our remaining time on this, but maybe just to hear from both of you a little bit about how you think about this, and maybe an idea about, or a concept about, how Medicare Advantage can be part of a solution in closing these gaps.
I think Medicare Advantage has to be part of the solution. Our orientation around managing the health of populations does give us the ability to think differently about how we measure disparities, how we set goals, how we reallocate funding to try to address the inequities that we see in the populations we serve. I think there are a couple key things. One is we should really think about how I think there's an opportunity for us to really rethink how we risk adjust so that we capture some of the social vulnerability in addition to chronic conditions. One thing that's quite clear from the pandemic is if you take care of a lot of minorities, they're more likely to both be unemployed, to be infected with the virus, to have adverse consequences from the virus. And we should not be creating perverse incentives to not enroll or not care for those most socially vulnerable. The other thing is, I think, there's opportunities, and I think in the future, I really hope that MA plans, we march arm in arm and we work together in communities to try to support those that are most vulnerable and fragile. I think, we should not be competing with each other on who has the best food bank network. We should be creating a food bank network together. And the more we work together on sort of really trying to sort of support communities with the fabric of the community as a team, we'll be able to better address these disparities.
So,
yeah, I would focus on a specific area that I'm particularly passionate about, which is MA as a potential solution to addressing homeless healthcare. I think there's an extraordinary opportunity there. John Backus, Jim O'Connell, and I had a perspective in JAMA last year around the idea of a homeless special needs plan. We presented it to Seema Verma, who was very receptive to it, and also to Brad Smith at CMMI. I think thinking about risk-based healthcare and building in modifiers that address the needs of these special populations could allow Medicare to be the financing mechanism to address some of the bigger issues. In a SCAN population, the RAF score for our homeless population is between 2.1 and 2.5, which gives you between $25,000 to $27,000 roughly in PMPY cost of care that you could apply differently potentially to address the needs of populations. So I think this is an amazing opportunity to serve some of our most frail and vulnerable people, homeless people in particular.
Great idea. Okay, with 2 to 3 minutes left, we're going to go into kind of lightning round, and so we'll take answers from the first person. It'll be jump ball. So, what area of supplemental? And these are some questions from the audience. So, thank you for engaging with us. What areas of supplemental benefit space would you like to see more innovation, and what kind of innovation are you interested in seeing that would help you out?
I would just echo Sachin's comments around the home. That we have a lot more flexibility in Medicaid today than we do in Medicare around supporting those with housing insecurity, and that is such an important correlate of health outcomes. It makes really good sense that we should have more flexibility to support that.
Absolutely. All right. So in telehealth, do you think that telehealth can be one of the keys to enable Medicare Advantage to address rural and underserved populations? So we're working off some questions here from the audience.
Yes.
Yeah, absolutely. And I'll say there's a lot
really
of
lightning, Will.
Let's go fast.
There's a lot of innovation kind of taking place in this space. There's a lot of new companies being formed in this. Again, I think it's a technology. It's not just telehealth virtual. It's also making sure that the diagnostics are available at the point of care in a way that people can use them, even if they don't have a clinician in their home. So there's a lot to build there, but people are building it. But so the answer is yes.
Okay. Here's another question. I think this one is important. How can Medicare Advantage plans better collaborate with other healthcare stakeholders, whether they be providers, pharmaceutical companies, medical device companies? How do we create a more collaborative environment between different industries?
Well, this notion, so I think we've all seen what happens when providers and payers are deeply, deeply aligned, and sort of category 4 prepaid, or global capitation, global payments for managing the health of a population to providers. The alignment is awesome, and the partnership is rich, and the data exchange is seamless, and we find ways to sort of leverage both of our clinical and analytics assets to be able to support populations better. We haven't gotten to that kind of alignment. We've talked a lot about value-based purchasing for pharmaceuticals. I think it's largely been window dressing to date. That idea of kind of continually moving towards deep alignment around both financial, clinical outcomes and the patient experience is ultimately going to get us there. I think because some things are so incredibly costly, and maybe there's no solution to that. Maybe there's probably need to carve out some really high cost but high value procedures so that we can we don't ration them, essentially. But yeah.
You mentioned analytics, and we haven't spent a lot of time talking about it. I mean, I see that as one of the major areas that differentiates managed models, Medicare Advantage, as well as the SNP models from fee-for-service, allowing targeting of benefits and the like. What do you think the future is of these kind of more analytic approaches to care, and how do they get better integrated into the clinical model?
Yeah, I'm actually really worried about this, Dan, to be honest, because I think there's a lot of folks who've never been a patient or cared for a patient who are kind of saying crazy things like AI is going to solve the world. And I think, ultimately, care in the senior population is really about behavior change. And so I think AI can help you identify who needs help, but people helping people is the most powerful means of actually, I think, delivering that help. And so, that's something that I'm eager to preserve and make sure we're actually, integrating into our approaches.
Yeah, this is a great topic, and one that I'd love to debate and discuss with the two of you. I mean, people helping people is obviously critically important. With that said,
it's better than robots helping people, but maybe you're going to argue the opposite.
But you could, I would say most Medicare Advantage plans couldn't do half of the things that they're doing in benefit design innovation without a very targeted model, and so that's really the place where I think you can have a lot of benefit. But
we're in violent agreement. I think identifying the sensitivity and the specificity of an intervention, getting the right things in the hands of the right people, and there's a lot of dead weight loss that's created, right? When you get benefits to people who don't actually need them, right? So violent agreement. But where I worry is when people talk about robots giving hugs. As a former person I work with, used to kind of put on slides. So
I'll kind of take what I can get at this point, given the pandemic. All right, I want to just take a minute to thank both of you for a great conversation, really insightful. We could continue to do this for a very long time, and I think Congresswoman Schwartz is going to be joining us in just a second to wrap this up. But is there anything, any final words that either of you want to throw out for the benefit of the group here before we do that?
Hey, it was just a pleasure to talk. I think we were muted, but yes, it's really great to see two old friends, and it is unfortunate we're not all in the same place together.
Yeah, thanks for a great discussion.
Very good.